Thursday of each month, we will be hosting a discussion featuring relevant stakeholders and experts about a topic in digital policy. The series is a partnership between the Digital Democracies Institute, the Center for the Study of Democratic Institutions, the Leadership Lab, the Center for Media Technology and Democracy, and the Center for Law, Technology, and Society. Today's roundtable is brought to you by the Center for the Study of Democratic Institutions at the University of British Columbia, looking at the issue of health communications in an increasingly and disinformed world. I also want to mention that today's speaker honoraria is funded via a SSHRC grant called the New Frontiers in Research Fund to study online abuse of health communicators in Canada. I am Supriya Dwivedi, the Director of Policy and Engagement at the Center for Media Technology and Democracy at McGill University, and I will be your moderator for today's panel. I'm just about to introduce the panel of experts we've assembled for you here today. But before I do that, please allow me to set the scene here just a little bit to give everyone an overview on the issue. Unless you've been living on an unmanned island over the last 3 years, you are in fact fully aware of the impact that the COVID-19 pandemic has had on public health communications. Whereas once upon a time, epidemiologists would go to cocktail parties with the bulk of people there having no clue what they did, the pandemic turned everyone into an armchair expert epidemiologist. Once the pandemic hit, all of a sudden you had these health communicators and public health officials thrust into the spotlight. And while there was for a brief moment a bit of a sense that we were indeed all in this together, that was extremely short-lived. And before we knew it, public health officials and other health communicators, including clinicians, researchers, scientists, health journalists, and civil society organizations, were dealing with online incivility at scale, with just massive amounts of threats, abuse, and hate pouring in. There is no doubt that there is an essential role of public external-facing communications in promoting public health, and those involved in doing so have shown an incredible dedication in getting the message out to different communities throughout the pandemic. However, in parallel, we have seen an inordinate amount of mis- and disinformation, as well as conspiracy theories that have polarized the debate around public health measures and have left many Canadians, and in fact, entire communities, distrustful of public health officials, health communicators, and really any public health measures meant to curb the spread of COVID. Unsurprisingly, all of this disinforming has had a very real impact on our discourse and has led to the polarization around public health measures, which, again, unsurprisingly, has resulted in worse health outcomes. Additionally, our political discourse on this front isn't exactly helping as politicians seek to use this polarization for political gain at the expense of social cohesion. What's more, as the Freedom Convoy demonstrated, the misinformation, disinformation, and conspiracy theories that exist in the online realm when it comes to COVID or public health measures don't exactly stay online, and they have a very real impact on the IRL or in real life world. Jurisdictions from around the globe are struggling with these same issues, as they too are having tons of difficulty in identifying and then employing effective public health communication strategies in an information ecosystem that is dominated by large social media platforms. Luckily, it's not all doom and gloom, as there are regulatory solutions to governing online platforms. The EU has led the way on this with their Digital Services Act, and the UK is following suit with their own online safety bill, with both jurisdictions demonstrating that there is indeed a way to tackle the incentives and algorithmic design choices by these platforms that push and amplify mis- and disinformation, as well as conspiracy theories over facts and reality. Canada won't be too far behind on this front either, as our federal government is soon going to be tabling our own bill that lays out a Canadian framework for governing large online platforms that will also tackle the systemic issues at play in our online ecosystem. Now, with all that said, let's dive into today's discussion. For our audience today, there will be a Q&A portion at the end, so feel free to put your questions into the chat and we'll get to as many as we can. Allow me to introduce our panelists. We've got Jagris Hodson, the Canada Research Chair in Digital Communication for Public Interest and Associate Professor at Royal Roads University. Sabina Vora-Miller is the co-founder of the Vora-Miller Foundation, founder of Unambiguous Science, co-founder of the South Asian Health Network, and Doctor of Public Health student at the Dalla Lana School of Public Health. Krishana Sankar is an award-winning researcher and trade scientist and is a science advisor and community partnerships lead for Science Up First. Harlan Pruden is the Indigenous Knowledge Translation Lead at Shimamuk, co-founder of the Two Spirit Dry Lab, managing editor of twospiritjournal.com, and advisory member for the Canadian Institutes of Health Researchers Institute of Gender and Health. Jagris, I'm going to start with you, if that's okay. What exactly do we know about how health misinformation and disinformation have spread during the pandemic? I've heard the term infodemic thrown around a lot, and I'm wondering if you find that's helpful or if it's accurate.
That's a great question. And yeah, I think it was the New York Times that termed the phrase infodemic, a portmanteau of pandemic and then information. So the idea is that misinformation, because of these new communication technologies and other factors, it just spreads so far, so fast that it is a worldwide problem. So the pandemic part of infodemic, and that it is getting in the way of our health, which is also why the term infodemic, I think, was created, is because misinformation was seen to be a real health threat during COVID-19. And that's not necessarily wrong, although the issue is, of course, more complex. So, for example, we had misinformation about masks and vaccines during the Spanish flu, right? In 1918. And the difference, though, with all of these new technologies, it allows anybody to post anything, and then the bad information to spread and to keep spreading until it gets picked up by, quote unquote, mainstream or traditional media sources, and then tends to travel even farther and even faster. But importantly, I think, is we need to consider the roles of some of these other players. So you mentioned politics, and I know we'll get to that later, right? We mentioned, is public health doing everything they need to do all the time? And we'll get to that later. But one thing that I want to bring up is people don't always care that the information is wrong. So flooding more information into this overwhelming information tsunami space isn't enough to correct the problem. And often scholars have shown us how people will say, well, I don't care, say that, that ivermectin doesn't work for COVID because I feel like the vaccine is dangerous, or I feel like I don't want to use masks because masks feel bad. So this feels like it's more true. So I'm going to believe that, even if you tell me it's not true. And then people have good reasons too for believing some of this stuff. Like they don't trust governments, and we'll talk a little bit about that later. They don't trust, right, the medical professionals, and even if they have one, and in Canada we can't get a family doctor. So, right, studies have shown, for example, that in the case of vaccination, a family doctor is a trusted source that can encourage people to get vaccinated if they're hesitant. But if people don't have family doctors, then we're not even there. So I think what I'm trying to get at is, yes, these new technologies have caused the misinformation to spread, but there's a reason why it's sticking. And we need to look more at the whole person and the whole society to determine why this misinformation is so sticky and why it is causing such huge problems. And I know my esteemed panelists can do more on that front as well.
Krishana, I'm going to go to you next. In terms of some of the key challenges that health communicators tend to face, what are they, particularly when we are talking about that online ecosystem?
Yeah, and I think Dagris, touched on a really key point too, talking about the infodemic and the influx of information. So I know my fellow panelists and probably many people on this call, we can all attest to the fact that just trying to keep up with all of the information that was coming into us during the pandemic alone was a massive challenge. And lots of us have expertise in this area, much less the general public, right? So can you imagine just keeping up with all of this, the different sets of information that kept coming in, and then from there having to distill all this information. Now we're distilling it in a manner that's understandable to those without expertise, and we have to do this in a timely manner, as well as keeping up to date on every single new result that comes out daily. And then the other thing is, we're not just speaking to one general public. We have many general publics, right? Lots of different groups of people who experience life differently. And so for that reason, having to tailor our messages specifically to the different groups so that they're relevant, they make their way into the groups, people actually understand what we're talking about. That has actually been extremely challenging. And I know Sabina and many other people probably in here can attest to that as well. And obviously talking about misinformation, countering misinformation. So not only because of the infodemic, we of course now had to battle so much information coming online. Now countering the misinformation came with a lot of backlash and harassment. We had harassment in the forms of trolling, I can't tell you how many times, I'd have a tweet out there and it's literally just the facts, absolutely no opinion. And so many very nasty messages would start to come. I had a specific experience when tweeting about when the first vaccine for kids came out. That was probably the worst experience I've ever had, where harassment moved from online trolling under the tweets to receiving emails of death threats. And I know a lot of my colleagues, unfortunately have been experiencing the same thing. And then unfortunately, sometimes coming off the email page, so coming off, the internet and finding your addresses and sending you physical paper, mail threatening your life. So these were some of the challenges just being within this space has really caused, especially within the last few years.
Harlan, let's bring you into this because, it's been alluded to, but there are all sorts of very good reasons for people to have a legitimate distrust of government mandated public health interventions. How should we be reaching out to communities who, again, for very good reason, don't really trust the government?
Greetings, or Tansai Nutatumtik Harlan Pruden, Ewaka no Mani, Niha, 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 Ayakwe. Kenonas Comtanina Wawa, Musqueam, Slawitu, Squamish. Greetings, my relatives. My government name is Harlan Pruden. I do have a spirit name. I'm not going to explain what that is. Both my name and what a spirit name is. And I also just want to humbly thank the Squamish, Musqueam, and Tsleil-Waututh First Nations, people whose land that I work, play, and live on. I'm First Nations Cree, or Nehiaw in my language, and I work here at the BC Centre for Disease Control within an Indigenous health program. So early on in the pandemic, I was a part of a research project, the QI project, where we were trying to assess where folks were gathering information. What were they gathering around COVID, and then to assess whether or not that it was a correct information or not. And then we also had questions around trust, and because we asked, for a breakdown of ethnic, we did an ethnic racial disaggregation of that, and separating out Indigenous respondents. And I'm only going to talk about the Indigenous respondents at this point. Why? Because there's huge mistrust in my community with government, and I am government. And why is because we've had incredibly racist, and as we've learned, when we have jawbones showing up, unmarked graves, a residential school system in which that 60 scoop, the current child welfare system. Do you know that there were more children in the current child welfare system than there were under the residential schools? To think that the government is still not policing and attacking us is a fallacy. And why and I know that within public health, I get some pushback of we want to do general public's work, right? Well, the colonizers, this country, had no problem singling us out as Indigenous people to attack us, to rip our children from the reservations and put us into boarding schools. Now you want to take an equality lens and have programs that talk to everyone? No, the remedy must match the harm. If you had no problem attacking and singling out Indigenous people, now when we're doing address is the centering of our cultures, centering of our identities. So that is one. Two, it was from the misinformation survey in which that we found that Indigenous people were just not listening to the current talking heads. And that they didn't trust the talking heads. One, because I think that, and we didn't get into, and I wish that we could do some more qualitative and gathering more stories, in which that we have another project that we're doing that, is that they could not see themselves. Many of the talking heads were white, cisgendered, of settler origins. Where were Indigenous people in that? And so what we did was there was an outbreak in Chayaskin. You all would know that as Kamen Lake, but the community, it's northern regions of the Secwepemc Nation. And what we found was that even though we were developing COVID guidance and we were working with a grade 6 or a grade 8 English reading and writing comprehension. We would do all this work of like developing our COVID guidance, and then we would pop it up on our website. What we found and what we heard was when this outbreak was happening within this community, that there was a lack of internet connectivity and or hardened software. Like the digital divide is very much alive, and it's a generational thing. Two, community members, and specifically our elders, who went to residential boarding schools, received an incredible education where they could not read or write to this day. And that there was levels of limited reading and writing comprehension. And so for us, even writing at a 6 or a grade 8 level and popping up on our website, completely inaccessible. And then there were also our community members that had learning disabilities that made textual-based knowledge translation products or information completely inaccessible. And so we met, quickly within like a 4-day period, we met with members of that community and we said, what can we do? And so what we did was we developed paper-based, grayscale, non-textual guidance. Illustrations. Some people go, those are such lovely cartoons. No, they're illustrations. And you don't have to read English to tell yourself the story. And we also had, female assigned individuals with braids, t-shirts with Indigenous designs. And so that Indigenous communities could read themselves into the guidance and they could see themselves in the guidance. And so I think at the heart of what we were talking about is knowledge mobilization, knowledge exchange, whatever you want to call it. We were just making information timely, culturally relevant and or sensitive. There is humility within that. And then to making it completely accessible to our Indigenous communities. And so what we also did was, as here in BC, some of the first publics that were available for vaccine, and it was age-based, were our elders, our Indigenous elders. And we as a committee worked and hustled so hard to not only develop a product that addressed vaccine hesitancy. It was really interesting how we did that. But two is all of the suites of all of our other things. And so when a vaccine site showed up and our elders were there, all of our products, how to stay safe, how to look after someone, was all there. And the elders, not only did they get a shot because they weren't vaccine hesitant, they were there, but two, they picked up all of the resources and they were the ones that were going back into community and like, listen, this is what this, and they became our deliverables within, because we equipped them with the information, but we made the information accessible, right? And so we were skipping, and that's how we were addressing misinformation. Now, we also heard anecdotally, because we didn't have time to develop an evaluation framework, because we were too busy responding, we do know that for our Chinese relatives within BC that struggle with English, we know our South Asian relatives who struggle with English. They were picking up our paper-based guidance, and they were going into community, and they're like, look at this. And they were over-reading the Indigenous braids and the t-shirts, and they didn't care because they could access the information. And so I think that there was this gem in which that laid. And so we within, although we were founded in the name of our working group as the COVID Indigenous Knowledge Translation Working Group, today it is the Indigenous Knowledge Translation Working Group. And we just finished a product on monkeypox, heat, and preparing for climate, response to climate, mental health, how to protect yourself and how to get over the glooms of either COVID deaths, elders deaths, or death from toxic drug supply, and mental, spiritual, and physical things that you can do to help lift some of that, the doldrums or the mental things. And so what we're doing now is going into other areas of public health, because we have this honed system that we have developed to get messages out that fundamentally address trust. And a part of that trust building is that we here in BC CDC, we don't go, what is Bonnie saying? And we're going to translate that. What are the health leaders saying? We'll translate that. What we do is we reach out informally to and formally to our communities. I'm like, hey, what's the chatter? What do you need help with? Is this a conversation that you need? And so we're taking direction from community rather than top down. And then if the guidance exists, like right now, we're looking at the drug DPIC, a Drug Poison and Information Center. We're doing this assessment within community. Is this information that you want? And then we'll translate it and make it accessible. Just because we think that we've invented the wheel doesn't make it the best thing, right? So we go to community and we get direction from community. And so there's kind of like this inversion of scripts. And then if the if community is asking for something and the guidance doesn't exist, then what we do is we use our places like for myself to advocate within the agency. Community is asking for this information. What's the science? What's the guidance? So that we can translate it and make it accessible for community. Right. And so there's like some really cool teachings. And so, from COVID, and definitely within the Indigenous communities, and also it's impacting other communities. We've created or are in the process of creating a similar sort of working group for our deaf and hard of hearing relatives, taking direction from them, developing guidance, and making it accessible to them. So we're just building these systems around knowledge translation, but it is to fundamentally address trust and to be in good relations with our Indigenous relatives, but also, more importantly, building those relationships with other communities or other publics who we talk to.
Right.
This is with the greatest honor. Thank you so much.
Sabina, let's bring you in here now. And I purposely left you for last as I was going around because I didn't want to come across as being victim blamey about this, but I don't think there's any real doubt amongst this group that some of the official comms that have been coming from public health officers and government has been, I don't know, suboptimal, to say the least. What comes to my mind right away is, not readily or really acknowledging that COVID is airborne, or, before the panel started, we were just talking about the risk that VIT induced by the AstraZeneca vaccine was playing early into the rollout. So have some of these suboptimal communications contributed to the misinformation out there?
Yeah, so first of all, great question. And the panel so far, the panelists responses have been incredible. Thank you so much, everyone, for sharing your perspectives on this really important topic. So, I think with public health, when things are working well, you don't know public health exists, right? That is the goal. The goal is you shouldn't know that they're existing in the background doing all of this work. So when you are actually putting limelight on public health, it means you're in a crisis. And so we're not just talking about communication, but we're talking about communication in a crisis. And I think that is where public health has really stumbled over the last 3 years. And we have a lot to work on to actually get us to a point where we are able to better, tackle the next pandemic, which I'm sure is going to be around the corner, given that we're not even, this current pandemic is not exactly over either. So one of the things that comes to mind for me as per our conversations before is just on transparency. I think public health has not done a really good job with respect to making sure that they're being very upfront and transparent about what the issues are. I think a lot of medical policy folks tend to do a lot of the talking in the background. They lay out the way things are. It's a very nuanced discussion. And then after that, it's like, well, what do we tell the public? Right? And that happens all the time. And I think we underestimate and infantilize the public's ability to understand complex topics. So I think we need to do a better job of this, because when we don't give the public the information they deserve, it erodes trust. And trust is so much harder to build back, right? And so your first goal needs to be that you're not eroding trust. And to tie in with that comes honesty. And again, we have not been very honest with things like, basic side effects that we can see with the COVID vaccines, and so, with transparency, the VIT was a great example as you brought up. On the honesty part from the very beginning, when people were commenting about possibly having menstrual cycle changes with the COVID-19 vaccines, from the top, from Health Canada and from other top officials, we kept getting the message saying, oh, there's no correlation. There's absolutely no correlation between the vaccines and menstrual cycle impacts. But I mean, when you actually think about it, given that your endometrial lining is like chock full of immune cells, and we see it with other vaccines, we see it with stress, we see these changes with infections, saying that it's not a possibility, again, eroded trust. In fact, we should say, we don't actually know at this point where we are, doing our due diligence. We are actually looking to see whether there are any impacts on it. It's plausible that there might be a small impact on menstrual cycle changes, but the important part is that it does not impact fertility. And here's why it does not, right? And we didn't do that. And again, I think we underestimated the public's ability to understand these concepts. And then again, we downplayed it, and that eroded trust. The other aspect that I think public health does not do a good job of is building uncertainty into guidance. And I think we have to become comfortable with uncertainty. And I think we hate it. And because we hate it, we end up giving out information in these absolutes. And when you are giving information out in absolutes, the nuance gets lost. And so how do you actually, give out information that builds an uncertainty, but at the same time reduces chaos, improves confidence? There is a way and a style to do this. And again, I think masks are a great example of this. We were told in the beginning of the pandemic that masks do not work. And this came top down from public health agencies. And in fact, we didn't know that. We absolutely did not know that. And we're still struggling with trying now to, share the benefits of mask wearing, why it's so important, because we missed that in the beginning of the pandemic, and we've never caught up with it. And I think also the other aspect is, and we don't do a good job of explaining this to the public, is why does evidence change? And to the public, it comes across as public health is flip-flopping, right? And in fact, it's just that science is moving at such a fast pace and policy is just always playing catch up. But again, I think explaining that, in fact, this means that we're being as evidence-based as possible, and we're keeping up with all the new information that is coming out. And it's so important that we're doing this. So if you're seeing us flip-flop, it's actually a good thing. It means that we're not stagnant. It means that we are actually updating evidence, updating policies based on evidence. And I think all of this gets lost because very often when we are communicating to the public, it's such a one-size-fits-all top-down approach, which time and time again has told us it does not work. And why we keep doing the same thing over and over again, I have yet to understand. So I think there is so much we can do to improve, our communication, improve our reach with the communities as well. That really should be taking into consideration all of these. But I will absolutely admit that we have not done a good job. In fact, we've done an abysmal job of communicating, and a lot of the issues we're seeing even now have to do with that.
Jagers, you've been very much nodding your head emphatically. Krishana, as have you. I just wanted to know if either of you wanted to add anything to what Sabina had to say there.
Sabina said it beautifully, but I want to underscore. So we did a study during the pandemic where we actually tested changing messages around masks and vaccines. And yeah, we found that if people expect that there will be changes, then they will absolutely come along for the ride, and you won't lose trust, right? But the issue is when they don't expect it to change, then they push back. So I think, just to strengthen Sabina's point there, yes, it has been shown that if we prime people by saying, the evidence probably will change, and that's a good thing, people will respond to that, that most people will come along for the ride.
Yeah, and then, so just basically underscoring everything that Sabina and Jagris just said as well. At least, so at Science Up First, which is actually an initiative of the Canadian Association of Science Centers, what we have been doing is creating these posts online. And although, and I think as Harlan mentioned, a lot of the publics are also not online. And in order to get into communities and the different publics, so different communities, we also have to find them in offline spaces. And one of the things when it comes to building trust and being really effective at getting that accurate information out there is using the relationships we have with different communities. So for example, one of our community partners, they work with a South Asian group. One of the things that they've done is they would take the information that we create at Science Up First, and they only take the pieces of information that they think are the most relevant, number one, to their community, and they would translate it into, you know, their own languages and share it among their community. So I think it's, when it comes to the trust and the building those relationships, is extremely important, and also about teaching that you know, uncertainty is where we're at, and sort of teaching people how to be comfortable in an uncertain situation. Those are some of the things that we've been doing with our community partners, and it's shown to be quite effective, actually.
Wanted to put this to the group that Professor Torek put in the chat here, but in terms of how we would go about encouraging public health to incorporate some of these evidence-based communication approaches, how do we go about doing that? Or if anybody has any ideas.
I think that what, first of all, I would like to fundamentally challenge the question of, like, evidence-based means Western knowledge production. And what I would like to do is create a space of evidence and wise practices. And wise is community knowledge and community practices. As someone who's doing their PhD in studying at sexuality and gender that existed within traditional Native American communities, your lit is blind to my study and to our stories and to this rich history. So just one, first of all, fundamentally challenge one, y'all are not experts. We're not experts. Two, and that whole expert status, and I think Kristen, that many of our panelists were, I'm sorry, I can't pronounce your name.
Prashana, I think you're referring to, yeah.
Yeah, is that there are other knowledges out there. So when we say, and we prioritize peer-based articles and peer-based generated knowledge at the exclusion of indigenous knowledge and ontologies, you're going to get into, so just one, wise practices in creating. And like what we're doing is had I gone to the literature of looking at the formation and the foundation and the theoretical constructs of the indigenous knowledge, it would have been not there because there's such few scholarships within that area. So that's one. Two is, I think that public health, because we've been working in the shadows, is I think that we have to do a charm offensive. I think that at the heart of many of these, the conspiracy theories is that we're tracking and monitoring, right? Prior to the pandemic, if there was a foodborne illness, we tracked it and we monitored it. We also did all of this like contact tracing and all of this like follow-up, right? But the public never knew that. You know, we would say Listeria outbreak. And they understand the systems that we had in place. And then COVID shone a light on that with our contact tracing and with like all of that other stuff. And people are like, they're monitoring us, they're chipping us. And so I think that we have to do a better job as public healthers to explain our systems of work that we have been doing since that water well and that pump, you know? And so I think that we have to do that. Secondly is that we have to do a better job of listening to community and taking directions from community. And then finally is that we must enter into relationships. I remember doing this focus group with Indigenous men that were recently unincarcerated, and they were living in transitional housing. And for this qualitative research project, we were trying to assess trust. How do we improve trust? And at one point, I was like starting to get really nervous because there was like the conspiracy theories were abounding, right? Like there was this one point, it was like it was like Joe Biden and their son, and there was a briefcase on a pizza shop. And I was just like, what is going on here, right? And so I started playing out like, where do I move this conversation, or how do I get to, and finally, 3 times, 2 different men were talked about like how that hand sanitizer is only effective like 98.6%. Like they knew that, right? And they kept on throwing of like, why do you talk like that, right? And So I was like, should I ask them who they are in their conspiracy theories? And I was like, I played out that, and I was like, no, that's not going to get. So finally, I just turned to them like, can you help me out? And what do you? And I was like, help me. And I was like, they're like, help you. And I was like, yeah, help us out, because we within public health, we try to provide the best research, both wise and evidence-based practices. And what we can say definitively is if you use hand sanitizers, it will be only 98.6% effective. Like, and I said, I wish that I could say to you, here's this hand sanitizer, 100% protection. Here, pop this condom on, you're going to be protected from HIV. We know condoms fail, and we want to be honoring of that because we don't want. And I said, so we try to tell you the most accurate information, but in most accurate is not going to be black and white. And then the conspiracy theories, they speak in absolutes. So help me. How do I talk to you and give you the right information? And I said, because we look silly, because we can't speak in absolutes. I wish we could, but science and research shows that it's not, right? And you saw the men, they were like, and I saw them just like, oh, you're being truthful. Absolutes are not truthful. And then the conversation became rich of like, oh, this is how we want to talk. We want to hear from ourselves. And they just gave meeting community, doing vaccine pop-ups on the downtown east side. And it's just, they were rich of like, and I was like, oh, there's knowledge here. And there's deep knowledge of how to fundamentally improve trust with Indigenous communities and the most marginalized, formerly incarcerated, recently released incarcerated men living in transitional housing. And they then became partners within my story. And so I just, yeah.
No, I was going to say, I mean, that Sabina, that touches on what you were saying, right, about the uncertainty and like kind of acknowledging that uncertainty or not speaking in absolutes. When I've touched on the online ecosystem, so let's get into that part of the discussion here. I mean, I'll throw this out to the group. In terms of the way social media platforms have leveraged to be able to amplify some of what those absolutes that we're talking about, and not acknowledging what the reality is on the ground necessarily. I mean, how does that work in your mind? Like, how have social media platforms really been amplifying the bad information over, let's say, the good information? And I realize I'm simplifying it, but I'm putting that in air quotes for a reason. Yeah.
Yeah, I'm happy to.
Yeah,
I'm happy to start us off. So right, the algorithms that guide what we see on social media are not optimized for public health. They're not optimized for news either, right? They are optimized to pull you in and to make you want to spend as much time on the platform as possible so that they can serve you advertising. So what does that mean in practice? What it means is sort of the same thing that we've been dealing with even since the dawn of like television and radio, right? The dramatic stuff gets you to stay. And that generally means things that are scary.
Yeah.
Things that make
like
us mad.
CNN breaking news like that. Yeah.
Yeah. Things that inspire disgust. And then to a lesser extent, you can see like the cute cat memes, right? Like that sort of thing. And so not only does that just on balance, favor the type of things that conspiracy theorists say, right? Because they offer easy answers to complex questions and easy answers to the things that we are afraid of. But then there's an added layer of, what some people call audience capture, which is these conspiracy theorists and people who are just simply maybe not a conspiracy theorist, but looking to make a quick buck, right? They will post something and then they will see that it's gotten engagement from the audience. So I post something dramatic, like what doctors don't want you to know, right? And then people are like, oh, this is exciting. And then the person doing the posting will say, oh, that post of what doctors don't want you to know, that got me a lot of engagement. So then they double down. And then that creates a self-perpetuating system. And we can't keep up. Public health can't keep up because it's like playing whack-a-mole. If you bust one type of communication style, then they'll just adopt another that breaks through. So we're always chasing it. We're always, playing a losing game, unless we recognize what my other esteemed panelists have been saying, that you have to get into communities. You can't just use social media as a broadcast tool.
Sabina, you're nodding.
I completely agree with everything you said. I mean, I think Facebook got into a lot of heat because of the fact that they had their algorithm that was sort of tuned into angry reacts, right? And so posts that actually got more angry reacts actually were the ones that were amplified in their algorithm. And I think that is an issue. I think, I think that we know that social media platforms are there. They're a for-profit business, and they make a lot more money when you get clicks. And how do you get clicks? It's by being provocative. It's by being sensational. And I think, I also think that we inadvertently do a lot of the same things, even though we're trying not to. I think, just in science communication, one of the things I see so often what people would do is they'll post something about something not being accurate, but they'll actually amplify the myth in their heading, in their title, or in their post. And I'm like, well, you really should be doing the complete opposite of this, right? And so I think that teaching healthcare providers, or teaching those in public health and other allied healthcare groups how to communicate on social media, I think is also going to be really important for two reasons. A, so they're communicating the right way, but B, also to fill the vacuum or to sort of counteract some of the misinformation that you're seeing a lot on social media. And I think that is going to be a huge priority for us going forward. So completely agree, with everything Jagrus had to say.
Prashana, oh yeah, go ahead, Harlan. Yeah.
I just like to pick up because I think that there was a gem, and what I see that we also must take into account with looking at online or social media communities is I also think that a part of this click, a part of the information, the sensationalization is there's also a yearning for community, connection, and a sense of belonging. And so, if you saw, having been fired by Trump, there's Team Trump. And you saw that, and there was these horrid stories that you saw after the freedom and the storming of the Capitol, thank you. And people were like, yeah, I gave my life savings. And then they were like, but I got nothing. They were vesting because they were looking for a sense of belonging and to be a part of a team. And then they were like, oh, I've been duped because I don't have that sense of belonging. And so I think there's what's playing out in that people are looking for that team, or that what I'm saying is community, connection, and sense of belonging as they flick control of oh, is this my community? I'm a part of something. Meanwhile, it's just their phone. But they know other folks are out there, right? And so I just think that we must take that into consideration also. There's the for-profit, and I absolutely agree with you. There's a sensationalization, but I think at the heart of that is really people are looking for a community, connection, and a sense of belonging. And I think that if you look at the work that we're doing with the Indigenous Knowledge Translation, is that we are creating that community of support, that community of practice by engaging with community. Where are we getting information? And we are fundamentally looking at how do we come together, which is incredibly important. And I know that we don't, as public healthers, we're like, let the science, but science has to be ruled by heart. And so we must maintain that heart and that heart-centered work. And that for us within our CRE, that is articulated by Sean Wilson and Evelyn Steinhauer, is all knowledge is relational. A priori to knowledge is relationship. And I think that we must keep this in mind. You can have a cure for cancer, but if you have no network to share it, or your language is completely inaccessible, do you have a cure for cancer? No. So what's the most important thing to invest in? Relationships, community, connection, sense of belonging. And you can do that within a public health sphere.
Prashana, keeping in mind with everything we've discussed thus far, let me put this question to you in terms of what lessons should we be taking from COVID for the next pandemic? Because as Sabina sort of alluded to, it's not like it's not gonna happen. So what do we do when it does strike?
So, I mean, for lessons, I just want to say every single thing that was said, I'm completely on board. I think we're all shaking our heads and, nodding our heads in agreement. And the lessons, that we need to take are some of the gems that have already been shared. I think one of the biggest things too is, we're talking about the algorithms and how, for example, Facebook will amplify things that, tend to take or bring strong reactions out from people. And so I think one of the lessons that we need to take and learn, especially as health communicators and even whether we're doing it online or offline, is really touching people emotionally. And so Harlan also made mention of this, is that people are looking for connection and community, and they'll go to places where they can find information, but then also find that familiarity, that community, and feel like their sense of belonging. And so when we are communicating our science, there is absolutely nothing wrong in sharing, personal parts to it. So we can attach stories as we also share the accurate information. That's actually effective. Research has shown that people will more, they'll remember quickly and recall stories quicker than numbers sometimes, right? Because we're actually getting to the heart of, we're connecting to the emotion of the person. So they'll actually recall a story based on emotion faster than they'll recall facts and figures, right? And basically, ensuring that we continue to harness the networks and the relationships that we've created during the last 3 years and take that forward. So a lot of our healthcare system, so public health and academia and industry and communities have all been working separately. But one really nice thing that's happened during the pandemic is that we've all started to work together. I think that is something we really, really need to keep moving forward. We need to continue to work together. I mean, without the community, and again, Harlan mentioned this, if there isn't someone to take those messages and translate it and communicate it out to people, how will they know, what is happening in one space? How will that information be translated to another space? In academia, so many things are happening in research or in public health. So many, the systems that are happening there, absolutely no one knew about it up until the pandemic shone a spotlight on it. Suddenly we're all communicating about it and everyone's interconnected. So I think it's also really important for us to keep that and push that forward as we go forward. The trust, transparency, and also capacity building. The capacity building, I think that Sabina touched on when it comes to really helping to teach, our society how to be okay, be comfortable with uncertainty, and then also learning how to spot and stop misinformation, I think is going to be extremely key, because as much as we all want to do that on our own, there's absolutely no way we can. So pretty much empowering people to do that on their own and use their own critical thinking skills as much as they can, I think will really be helpful going forward as well.
Sabina, like a lot of folks that I sort of mentioned that have been public facing in terms of their public health outreach communication efforts, have been subject to just all sorts of general terribleness and online abuse, including threats of violence, death, rape, etc. I've have perused your mentions from time to time, and I know you've dealt with quite a lot of online crap as well. What types of policy changes would you like to see by the platforms that would, help address some of the online abuse, but also like the core disinformation proliferation problem that we tend to have?
Yeah, I think we're at the spot where everyone's sort of washing their hands and sort of blaming each other or pointing fingers to say, oh, that should be so-and-so's responsibility. I think it's everyone's responsibility to make sure that places are safe spaces for everyone, and especially women and women of color, who are generally the ones that bear the brunt of this toxic culture that you can see spreading right now. I mean, I can tell you from my own personal experience, the worst 2 weeks of my life were when it was right at the heels of the trucker convoy occurring in Ottawa, and I was one of the signatories on, requesting that Spotify have a misinformation policy in place, given, some of the folks who were brought on to the Joe Rogan experience, and the vitriol that sort of followed that, quoted by certain people, including Donald Trump Jr., literally led to the worst 2 weeks of my life, right? And it was interesting because I was going through all of this, going through people sending me these, frankly, absolutely vile death threats. And, someone had to think about it, someone had to write it, and someone had to send it. That shows you layers of,
intentionality.
Yeah, exactly. Into it. And so, and I remember taking this, and people would say, well, you need to go reach out to the police. You need to go reach out to so-and-so. No one did anything, absolutely anything. And everyone said, well, this is not our jurisdiction. You need to talk to so-and-so. And I just kept getting passed around. And I literally dropped it. I dropped it at that point because there was no recourse for me, right? And so we need people to take accountability for things that are happening under their watch. And that includes social media platforms, actually having, very clear policies on what they do and do not tolerate. And when policies are broken, especially when it comes to death threats and things that are completely vile, there needs to be accountability for social media companies that do not actually tackle this. And I'm not talking about a simple slap on the wrist. There needs to be true accountability on this. And then having, as you mentioned, we're going to have a federal plan in place. We should have had this many, many years ago. Social media bullying is not a new phenomenon by any means. Why has it taken it this long? To the point where there are people who are in public health who've lost their lives because of, irate people, trying to settle a score with them. And this has not been done. And then there has to be clear policies, even with law enforcement, on how they're able to actually have our back when things like this happen. And I know for me, I was terrified about people having my address. I was terrified for my family, and I was doing all this work volunteer. And so, I began to question, why am I doing this, at the expense of my family and my safety? Is it worth it? Is it not? And until we get to a point where we can actually make this space safe for everyone, I can tell you so many, women, especially women of color physicians, who want to have a more public facing, or just be able to communicate, their experience, their public health knowledge and information, but they're terrified to do it because of some of the drawbacks that come with it. And I think we need to make the space safer for all of them. And until we do that, we're not going to see proper representation in social media.
We've only got about 6 minutes left, but there's a couple of really good audience questions that I want to get to. One of which is, completely agree with the need to get into communities and creating those connections, but how do you supersede the trust individuals put in their own circles? And then the questioner goes on to reference those closed loop messaging systems like WhatsApp, right? And I just, coming from the South Asian community, I often joke about the WhatsApp auntie and uncle disinformation chain, because it is something that's like very real. So how do you break through to that?
Sorry, can I jump in this really quickly? Because I know when we were talking about, where do they accumulate WhatsApp and South Asian communities? I mean, the number of times my dad has said, so-and-so auntie sent blah, blah, blah about the vaccines. And I'm like, oh my God, Dad, can we stop? But it's so true. And I think the point over here, and Harlan has made this point so eloquently, as has Krishana, but we leverage the trust that people have in their communities. And we've done this, and there's really, really good examples of how we've done it really well here in Canada. I mean, if you look at Toronto Public Health, Ottawa Public Health, I think both of them on a more local, more regional level have really embodied it. And again, it comes down to the fact that we can't have this top-down messaging coming. We have data to show that it does not work. So how do we do it? We actually try and infiltrate and leverage trust that we have with our community members. And I can tell you the work we did with the South Asian community was exactly this. So we reached out to our, our temples in the area, and we said, we know you guys have a WhatsApp group. It has so many members. can we come in there and talk, and or maybe can we send you some information that you can share within your WhatsApp group? So we're using the same tactics, but we're actually putting in information that we want out there, right? And so we did that with WhatsApp groups. We did that. We basically, you know, hijacked the Punjabi radio station that we knew that people would be listening to, and it was like 7 o'clock in the morning. We knew everyone's going to be listening to it. We tuned in. We put our messages out. And we did that. And, you know, when we had pop-up clinics in these high density South Asian communities, we called up businesses in the area. And in fact, when they had questions on the vaccines, we spoke to them. We spoke to them in Hindi. Like I did so many calls in Hindi, you know, explaining some of the questions that they had. But you do it, you know, through these connections that you have in the community, and you find out where your people are, and you try and actually, you know, meet them exactly where they are. Don't expect them to come to you. You need to go to them.
Yeah, and if I can jump in here, so I think that was an excellent question because, so I mean, you know, for myself personally, and then also working with Signs Up First, one of the ways that we've been doing it, and probably one of the most effective ways, is if I'm not part of that particular community, but we are working with these communities, we speak to the people who are, you know, the influencers of that community, who are the leaders and the heads of those communities. So for example, you know, we've worked with a few faith-based communities, right? Like if I'm not part of that faith, you know, or part of that community, you know, why would they listen to me, right? So we're working with those, you know, faith leaders, for example, you know, if they have questions, we talk to them, we give them the questions. And I think just like Harlan mentioned before, they now take that information and go into their own communities and share it back with everyone else. And by using this model, it has been actually quite effective because then, you know, we have that trickle down effect where that information is disseminated within those communities by the people that those communities actually trust. So, you know, whether it's a pastor or an imam in one community, you know, we've partnered with a few different Indigenous communities that are doing their own phenomenal work in Saskatchewan as well. Again, you know, they were leading everything. We just spoke, you know, with one of the, you know, one of our connections, you know, from a Cree nation, and they came back and told us, you know, they're like, okay, these are the things that are happening in our community. These are the things that our community wants to learn about and know about. You know, we did not say, well, we are working on COVID, you know, content. We said, what do you need help with? If you need help, they told us what they did. We said, well, here, you know, here is access to all of our information. They took that back, you know, ran with it, had their own events, you know, printed out their own posters, disseminated the information the way they knew how to, and that would work best. And then came back to us and gave us phenomenal feedback that said, you know what, this worked excellently. This is the type of partnership that we have had, and it's worked really well so far.
I'll jump in and say that all of these examples, Sabina's, Krishana's, Harlan's, it just shows, like, the question is, how do you supersede the trust in individuals, you know, in these communities? You don't supersede it. You use the trust, and I don't mean use it in a bad way, but also you can't respond to misinformation after the fact, right? You kind of have to be proactive in being involved with individuals in communities. And Krishana, I love the idea that you're not going into the community, but you are working still with the community so that the leaders in those communities can do it. And I think that's just super important. We're not superseding trust. We are putting the trust in the communities, and we are allowing the communities to do what they do best.
Harlan, we've got like 30 seconds left if you want to give some closing thoughts here.
Oh, goodness. One, I also think that just amazing panel. One, we need to come back together and have this more conversation, right? But I think there is also some important contextual things around COVID. In that, for public health, from COVID, is that the local, national, global, and international elite were scared. And as a result of that, they just opened up their checkbooks, and there were unlimited resources that we had access to address COVID. So what we can do if we had unlimited resources is amazing, to contextualize this conversation. Two is, and I see this all the time, in that we within public health, for the very first time, everyone was of lived and or living experience. We were also scared. When we were developing guidance, when we were doing all of our interventions, both clinical and non-clinical interventions to address COVID, That person sitting in the room or that community before us could have been our aunties, our uncles. And so not only were we being sympathetic, we were being completely empathetic. And think of the conversations as well as the work that happened because we were of lived and or living experience. I know around HIV, many of the folks are MSM, but there are many that are not. And so they don't know that lived and or that living experience. COVID made us all impacted, and we were developing guidance not only for myself, but for my loved ones and my communities. How cool would it be if we had unlimited resources as well as we're of lived and a living experience? That, I think, is where we have to move this conversation, where we witness and honor each other's humanity and we sit in good relations with one another. Yes, even with the trumpeters, even with the freedom convoyers, that we must invoke love.
Great place to end. Thank you so much to our panelists, Jadris, Harlan, Prashana, Sabina. Wouldn't have been able to do this without you. So thanks again, and we'll see everyone next month. Bye, everyone.
Thank you.